Good afternoon, everyone. So my name is Carmen Anderson. I am here on behalf of the U.S. Medical Compression Alliance, and we have invited some wonderful experts within the industry and from the DME Max to join us as well, and for the advocacy groups to discuss what we've learned in the past year and a half since the implementation of the Lymphedema Treatment Act. So for our panelists today, we have Kara Bockheimer joining us from Brown and Fortunato, Heather Ferguson from the Lymphedema Advocacy Group, Noel Neal from AccuServe, Belinda Yandel from CGS, and Corinne Medina from Noridian. We're going to do a quick overview, and starting with the DME Max, they're going to go through a Medicare coverage recap, and then Noel is going to talk to us about billing best practices and preparing for audits. Kara is going to touch on the proposed rule and competitive bidding. Heather is going to touch base on the denial reporting form and supplier directory for LAG, and then we'll wrap up with Q&A at the end. So with that, I am going to turn it over to our DME Max experts. Thank you. Belinda, you're on mute, so you'll have to come off mute first.
Well, that's embarrassing. It's the way my Monday's been going. I'm sorry. My name is Belinda Yandel. I'm with CGS Provider Outreach and Education. Corinne with Noridian is my counterpart, and we're going to both be talking about the Medicare standards for gradient compression garments. So starting off, we've got standard and custom daytime garments and wraps. These are covered by Medicare, 3 per affected body part, and they're replaced, they're 3 every 6 months. For nighttime, it's 2 per affected body part. And what we're talking about is if you've got an ankle and you've got a thigh, then that's 2 different body parts. So 3 or 2 for each of those things. The accessories necessary, they are covered. There's no set quantity, but you got to have justification documented in that medical record. Compression bandaging systems and supplies, if they are phase 1 and phase 2, they are eligible. And the quantity is at the discretion of the DME. Our reviewers look at the documentation to see what's justified, and then that will be what they decide to cover.
So lymphedema compression treatment items are covered under the benefit for beneficiaries who are diagnosed with lymphedema, provided that they have one of the applicable diagnosis codes that you see on this slide here. So those include lymphedema not elsewhere classified, hereditary lymphedema, post-mastectomy lymphedema syndrome, as well as other post-procedural complications and disorders of the circulatory system not elsewhere classified. Now, coverage under the benefit for any non-lymphedema diagnosis is prohibited. So that means that the claim is going to deny without the proper diagnosis code.
So supplier responsibilities, this pretty much is across the board for any supplier of Medicare items. They can only be furnished if you are enrolled in as a DMEPOS supplier. That goes through the National Provider Enrollment. They take care of all the information that you're required to have on file, and accreditation is on file. Again, and we, the DME Max, CGS, and Noridian, we are the ones that process your claims. And of course, again, as I mentioned, all of the Medicare items, there are supplier standards that you can find in our supplier manuals. You can also find them on the CGS and Noridian websites. We've got some information at the bottom, some links to get you to all of this information and talk about what's covered on a claim-by-claim basis. There's accreditation. Again, you have to be accredited to work in a specific line of products. Quality standards, again, and this is pretty much standard across any good business, and any other requirements that would apply to enrolled DMEPOS suppliers. as far as things about participating and non-participating, that information as well.
Now on this slide is a handy little graphic that was created in order to show the distribution schedule for daytime lymphedema garments, just as an example and to provide a visual. So you can see we've got three different scenarios outlined here. In the first one, scenario A, you can see that one item was received by the patient in January, and then the other two items were received in March. So that would mean that in July, 6 months after that first order was received, all three items are eligible for reorder. Then in scenario B, you can see all three items were received in January, which means that 6 months later in July, all three items are eligible for reorder again. And then lastly, that scenario C, we do have one item received in January, another in March, and then the third in May. So because that first item was received in January, that means that the 6-month reset is going to occur in July. So that means that the beneficiary would be eligible to reorder 3 new items in July.
And when we talk about replacements, these items, if they are lost, stolen, or irreparably damaged, and generally by irreparably damaged, we're talking about something that happens in a single specific incident. This is not talking about wear and tear on a everyday basis, but for daytime garments or wraps, and you're replacing for one of those reasons, you do need the RA modifier on your claim. Again, it's payment allowed for 3 compression items or wraps per affected. We used to say extremity. Now we're finding it is much more accurate to say body part. It eliminates some confusion. Again, frequency limitation is once every 6 months for daytime, and the 6-month restarts, as Corinne went over, on replacement of any date of service for the items that are being replaced. Nighttime garments, you do need the RA modifier. Again, payment is for 2 garments. And again, it starts when any item is replaced. That resets your 6-month or 2-year clock for whatever kind of item you've got. Now, notice if the beneficiary has a change in their physical condition, their medical, you would not use the RA modifier because you're really not replacing the same exact item. Generally, if there's a change in their physical condition, their medical status, you're going to be needing to replace it with something else that better meets their needs. Therefore, no RA modifier.
And now we'll quickly talk about what to do if you receive a denial. So your remittance advice will advise you if you've received a denial. And then from there, you can either rebill, which means to correct the claim and rebill it. You can also reopen it or submit a redetermination, depending upon what is in that remittance advice. Noridian and CGS both offer tools to resolve denials, and they can be accessed through these links on the slide. The tools will identify what the denial code on your remittance advice means, and it will provide guidance as to how to resolve them, as well as how to avoid them in the future. And then we also have some links to our portals as well for ease of reference. So these are some great resources to use if you are encountering any denials.
And this is a look at the CGS Medicare resources. You'll find a lot of the same great resources available on, both Noridian and CGS. CGS has jurisdictions B and C. You've got that claim denial help tool, the supplier manual, which is great for just about any kind of question. It takes you everywhere from enrollment all the way up to appeals. Standard documentation article, which pretty much covers the overview of any documentation for any Medicare item claim being distributed. And then our webinar and workshop calendar and tools and calculators. We've got a lot of tools that can help you make your life easier and your claims more likely to go through quickly.
And then we have pretty much the same resources, but for Noridian. So at the top here, we link our Noridian homepage, and that's for, excuse me, jurisdictions A and D. And then we also do have a page dedicated to billing, claims, and appeals, which will outline requirements and scenarios for billing, submitting claims, as well as the appeals process. We also have the links to our supplier manual and the standard documentation requirements policy article that Belinda just mentioned as well. Also, there's a link to our schedule of events, so you can be aware of upcoming webinars and Monday live chats. You can register for those. And we also have tools on Noridian's webpage as well. There's about 50 different tools here that cover all different DME policies, so those can be excellent resources for you. So if you are a supplier in jurisdictions A and D, I definitely recommend checking these resources out. And with that, we're going to hand it over to Noel.
Thank you, Corinne and Belinda. Great presentation. Hi, everyone. Noel Neal here, Chief Compliance Officer at AccuServe. At this point, we're probably the largest third-party billing company. I want to go over some billing practices and preparing you for audits as we start seeing audits ramp up. So really getting into billing best practices, when you're looking at payers, whether it's Medicare or any other particular payers, you want to understand the documentation requirements, because that's going to be important. Understanding what qualifies and what doesn't, and not all policies are created equal. Not all policies follow Medicare guidelines. Some are more strict, some are less strict. So make sure that you review the policy when one does exist. Billing reminders and billing requirements are also important. The modifiers for Medicare don't always translate into every payer. Understanding your payer is going to be important. Your payer may have specific modifier. I know Corinne and Belinda did a pretty good job in outlining the quantity limitations and frequency for certain products, certain garments. That doesn't translate into every payer. So make sure that you understand how often your payer, whether it's Medicaid, Medicare Advantage, and also for private payers, self-funded plan, understand the limitation is going to be important. Billing for NOC codes, not otherwise specified codes, is also important. Medicare gave instructions as to how those need to be billed. The instructions may vary. I've seen some plan that require you to drop that to paper and mail it in because they want to see a copy of the invoice. So just make sure that you understand that authorization requirements. On the Medicare fee-for-service program, you understand that there's no auth required for these items. But under Medicaid Advantage plans, there may Medicaid and so on. So knowing the guidelines for your payer is going to be very important in understanding how do you best navigate the terrain to be reimbursed in a timely manner. Also, one of the things that I recommend is always optimizing your price table. So now that you've done the research, you understand what modifier needs to be billed, the quantity limitation, whether or not authorization is required, update your price table to reflect such. If your price table says you have to bill with this modifier, then that way, before the claim leaves your system, there's an edit and check in place to make sure that the claims are not billed erroneously. If authorization is required, you can configure your price table to make sure that the claim doesn't leave the system. It flags someone to say, wait a minute, an authorization is not linked, because that way it also helps you from dispensing an item without getting an authorization if you put the appropriate holds in place, checks and balances, because not all insurance companies are willing to give you retro authorization. So it's called prior authorization for that reason. You get it before you dispense the item. If you dispense the item and try to get the authorization, there's some plan that will allow you to get retro auths, but most insurance companies will not allow you to do that. Updated allowable. Sometimes we've seen some allowable where they put the build and the allowable to be the same. Your build is typically a little bit higher. It's your usually customary, but your contract typically stipulates how much you get allowed. It's very important to make sure that your allowed amounts are as accurate as possible, because one, it helps you in forecasting. It helps you understand how much you're really expecting to be paid and not just the inflated billables, right? And it also reduces the back-end work for your billing staff and your posting staff for doing the contractual adjustments on every claim, when that could have been done more efficiently had your allowables be updated. And final billing practice here, recommendation here is tracking your denials. Having denials by payer, I know at AccuServe we have robust tracking mechanism that tracks denial down to the level at a payer level. But you may not have something as robust, but it's very important to track your denials. Know where you're getting the denials from so that you can make informed decision. If there's a particular payer that is denying your claim all the time and you're not getting paid timely, then you might want to consider how you approach that payer, take in future referrals, or have a much larger conversation. DSO and aging, date sales outstanding. We know these are metrics that we track from an AR perspective to see the health of your company, the financial health, and establish KPI metrics to ensure that your company is important. Make sure that your aging over 90 doesn't exceed a certain threshold, whatever you determine to be appropriate for your organization. And then some billing reminders. Again, checking for prior authorization. When you talk to someone, if they said prior authorization is not required, make sure you take the name and the reference number for the call. Because on the billing side, I can tell you many times we've had instances where they said prior auth isn't required, and when the claim is billed, then it's required, and you have nothing to stand on. If you take the name and reference number, you can use that for your appeal. Check in to make sure the doctor is enrolled in PCOS and can prescribe the garments is important. One of the things that we see people do, they check it for the primary, but they don't do it for the secondary. Certain state maintain their own databases of physicians being able to prescribe certain things for Medicaid recipient. So make sure you're checking for those as well. Under SNF, we know that if the patient is in a Part A covered SNF, then these items are not separately payable. Make sure you're checking for that within eligibility. On the Medicare program, make sure you're checking to see if they have Medicare Advantage plans and you don't assume that they have just fee-for-service. Home health episode, we know that the lymphedema garments, we had a scare at the beginning of the year, but we know that these garments are separately payable by Medicare if the patients are enrolled in a home health episode. And last on the list, same or similar is also very important. Make sure you check those utilization. Medicare has portal. Some of the other payers do not, so you have to call to verify that the patient has not already gotten or exceeded their allotted limits of these garments. So keep a watchful eye on that as well from a same or similar perspective. So billing caution, just wrapping up here. Just want to remind suppliers that charging for upgrade within a HCPCS code is strictly prohibited unless you have an ABN notifying the patient of that upgrade. And there are certain scenarios where that is allowed and there are certain scenarios where it's not. So for example, the only time it is allowed for you to charge for an upgrade within an assigned HCPCS code is when that item itself has features that exceeds the official descriptor of the HCPCS code, okay? So you can't just charge an upgrade just because it costs you more, or maybe the color looks prettier, right? Maybe it's a pink. So some of the prohibited use, and you cannot charge a patient an upgrade if you've billed a claim, whether it's on a assigned or unassigned basis, if you've never given them the upgrade option. So the patient must know before you dispense and deliver and bill that this item may not be covered and the reason why, so that they can make an informed decision. You cannot do that just because it's a better quality. Maybe in your opinion, one manufacturer is better than the other, but the descriptor of the HCPCS code is exactly the same. You can't just charge just because you think it's a better quality. So just there's some prohibitions, be aware of them. Violating these law repeatedly can lead to suspensions and civil monetary penalty. Insurance companies, other insurance companies might have within their policy as well prohibitions for charging patient upgrades. I've seen some contracts on the private side where they said that the only fee you're allowed to charge their patient would be the patient's cost share and responsibility, which is often defined as copay, deductible, co-insurance, or out-of-pocket max that they've determined. So I would suggest before you establish a protocol of charging for upgrades or any additional fee that you consult your healthcare attorney and or your compliance department. And administrative fees, another one that we see, we hear about in the industry. Again, just be careful, guys, because most time your contract prohibits you from charging additional fees that are outside of the fee schedule. Typically, when the fee schedule is negotiated and agreed upon contractually by both party, the fee accounts for everything, including administration, the delivery, and the provision, the education, and so on that is involved in the care plan. If those rates don't commensurate with what you do, you should have discussions with the plan to make sure that those rates are negotiated to better reflect your reality, rather than passing on additional administrative fees to the patients. Those administrative fees can be viewed as violations of your contracts, and it may subject you to scrutinies, including litigation. So be careful, be mindful of the administrative fees. And then just final 90 seconds here. Just a reminder, if you are in this business, if you're doing Medicare, make sure you're compliant with all the Medicare quality standards, the Medicare supplier standards. It goes without saying, this is not an all exhaustive list, but just some reminders. Make sure that your surety bond is updated. If your surety bond cancels for any reason, make sure that you are proactive in communicating this to the MPEs. Make sure that your licenses are updated. Managing employee, if you have managing employee, they're required to be on your PCOS records. If the Medicare shows up and someone says they're a director and they're not listed on your file, it may be a problem for you. So just be mindful of that. Cost share and responsibility. Make sure that you are collecting or making a reasonable attempt to collect the patient's co-insurance, because that can become a problem. If you are waiving copays or not making a reasonable attempt, whether it's on the Medicare or private side, that can be a problem for you. And just assigning someone within your company to actually monitor these changing policies. I think Aetna recently pushed out a new policy. Make sure that if you're a contractor with Aetna, you're reviewing that and how that impacts you, and make comments. Reach out to the plan if you don't agree. Next slide. And prepared for audits. Let me try and do this in a 30-second cliff note. Audits are coming, guys. I hear stories of UPIC audits that are coming on the Medicare side, and different audits that are happening, which is to be expected. It's a new benefit. It has run its course. So no, there are audits out there. I'll see a lot of audits on the commercial side, SIU and different things. Make sure that you have all the medical records to support the items being provided. Make sure you have those on file and available. Just some quick reminders, at least from a CMS perspective, LMNs, templates created by a supplier, even if they're signed off by the doctor, are not considered medical records. A prescription is not considered medical records. So make sure that you have medical records, progress notes, notes from therapists. Those are considered medical records, and have those available because the auditors are coming. And then last and final, just make sure that your packages are organized. What we do typically is we put a separator sheet. So we'll have order, a blank sheet that says order, right? And following that will be the order, proof of delivery. So the more organized your files are, is the more higher probability that you will be successful in the audits. If the auditors have to go all over the place for documentation, it's a very good possibility that they will miss some documentation. So auditors are coming, prepare for them. Make sure that you have all the right documentation that supports the claims that you've billed, so that you can justify, respond to them timely, and ask for extensions if extensions are able to be granted to allow you more time. But don't ever not respond. That's the worst thing you can do for any auditing entities. And with that said, I think that is my last slide, and I wanted to turn over to my friend Kara from BNF.
Great, thanks Noel, great job. And thanks everybody for tuning in today. I'm going to talk about something a little bit different for the next few minutes, something that's not in effect, may or may not affect this audience, compression garment suppliers, but we want to make sure that people are aware of what may be coming down the pike. CMS or Medicare publishes annual payment rules for most providers. And in this year's proposed rule for home health agencies, they included significant changes to the DME competitive bidding program. This proposed rule was published on June 30th, officially in the Federal Register a few days later. And there's not only changes to home health, but there's a significant number of changes to the DME competitive bidding program. And we're going to talk about that. There was also some proposed changes to accreditation, which will apply to you, as well as potentially some prior authorization changes, and also some changes to the enrollment section. So there's a sweeping number of changes that are being proposed, and the original Lymphedema Treatment Act that Congress passed did give CMS the authority to include these compression garments in future competitive bidding programs. They did not mandate it, they did not require it. So we don't know yet whether or not CMS is going to include these. This is a proposed regulation. It does not include a list of items of product categories that will be included. We would expect that later on down the line. But the important thing about this proposed rule is that it provides a series of regulatory changes in a proposed format. And we're currently in the middle of the public comment period. So we'll stay tuned as we move to the next stage. So the typical implementation timeline for both the regulation and vis-a-vis the competitive bidding program, the comment period closes in a few weeks at the end of the month. We would expect to see a final rule released by CMS around November 1, and the final rule technically goes into effect on January 1st. All the other decisions, and most notably product categories as well as the geographic areas, will be announced by CMS on a sub-regulatory basis. So there's a website that CMS has. They also have a competitive bidding implementation contractor. And so all of the subsequent information will be posted online, will not be part of the actual technical regulation published in the Federal Register. So what we're seeing about this particular administration, a lot of what we're assuming in the past may not be happening in the future. Our understanding is this administration wants to move relatively quickly in terms of implementing a new program. So we may see product categories and geographic areas announced sooner rather than later, possibly before the end of this calendar year. Otherwise, we would see it early in 2026. So this is not an exhaustive overview of the changes because there's a lot in here. But in terms of the potential changes for the bidding program, and as they would pertain to the provision of lymphedema compression garments, we're going to go through a number of sort of the more technical areas of how the bidding program operates, which will be important if these items eventually get included. Aside from that, I want to mention at the outset the accreditation changes, which will impact you if you're a Medicare supplier of any items under DME. And that is CMS is proposing to change the triennial requirement to an annual requirement. So they are proposing to require every DME supplier at every location be surveyed every single year. CMS is also proposing some significant changes to its revocation authority, pretty significant proposals that would give CMS and Medicare significantly more unilateral authority to revoke supplier numbers. So it's important to become familiar with those proposed changes as well. So in terms of some of the key areas within the competitive bidding program, and for those of you not familiar, I'm going to do a little bit of background. This bid program has been around for almost 20 years at this point, and there have been numerous bidding rounds that have covered sort of the traditional DME areas. The way CMS regulations currently require bidding is on what is called lead item bidding. So what that means is within a product category, say there's, and I'll just use oxygen, where there's 20 HCPCS codes, only one HCPCS code, for example, the oxygen concentrator, the item that Medicare spends the most money on and is most utilized, that's the only item that is bid on. And then all the other non-lead item bid prices are reduced based upon the current ratio of the payment amount of the non-lead to the lead item. And CMS is proposing to make that a state-based ratio. It previously was national. And lead item is different from how CMS previously did competitive bidding, where bidders would bid on every single HCPCS code. And so while lead item bidding might be more administratively simple, it also assumes, and we don't believe this is correct, that there's a rational relationship between the prices within product categories. because everything gets reduced by the same percentage, essentially. On the bid ceiling, CMS is making some significant changes in terms of lowering the bid ceiling. If an item hasn't been included in a competitive bidding program before, as in compression garments, if they do choose to include them, the current fee schedule would be the bid ceiling. However, in subsequent rounds, that bid ceiling would be based upon the previous, what we call SPA is the single payment amount, which is really the same thing as the bid price. So it would be the previous bid price plus 10%, essentially. They have a lesser or formula, but as a practical matter, it would never be as high as the earlier fee schedule. So the theory is that the SPAs would continuously decrease over subsequent rounds of competitive bidding. In terms of the number of contracts awarded, when you read through the preamble and the proposed rule, CMS is intentionally wanting to reduce the number of contracts that are awarded compared to how many were previously awarded. And they've developed these two very specific proposed methodologies for determining the right number of contracts per product category. Now, in competitive bidding, bidders bid on a product category in a bid area. Historically, there have been about 120 geographic areas, the largest metro areas around the country, that were each individual competitive bidding areas, or CBAs. And so there would be a distinct group of contractors for each product category for each CBA. And what CMS is now proposing, in order to determine the quote unquote right number of contractors, they would take a number that is the equivalent of 125% of the number of suppliers that furnished at least 3% of the total utilization of the lead item in the product category and the bid area during the most recent calendar year prior to bidding. So note, this is a way to calculate the number of bidders. It is not, if you're not doing 3%, it doesn't mean that you're not eligible to receive a contract. But it is a formula that is CMS is going to be using. And for product categories that have been previously included in prior competitive bidding programs, the number of contracts would be no more than double the number of contract suppliers that previously furnished at least 5% of the items or services. One of the reasons that that CMS is proposing this, in the past, CMS determined the number of contracts based on a combination of factors, but importantly, the capacity of suppliers. Suppliers reported basically how many items they could provide over the course of the contract period, and CMS used that information along with their Medicare utilization to give each supplier essentially a reported capacity and add up the suppliers till they got to the right amount to meet the expected demand over the 3 years. So this is a radically different proposed methodology, which appears to be solely based upon an objective to limit the number of contractors. And in that same vein, CMS is proposing to change the minimum number of contractors for a product category, for a competitive bid area, down to 2. The current regulation states that the minimum number of contractors would be 5. So again, that's another dramatic reduction in the number of contractors. Calculating the SPA, CMS is making some significant changes here. And remember, the SPA is the single payment amount, which is equivalent to the bid price. Under the current regulations, the bid price is calculated essentially at the last man in. So the way CMS will array bidders from low bid to high bid, and when they get to that magic number, based upon those formulas that we just reviewed, the last man in bid would be the one setting the bid price. CMS is proposing to change that by reducing it to set that bid price at the 75th percentile. So if you have 10 contractors between number 1 and number 10, the bid price would be set between the bidders' prices who are number 7 and number 8 in that lineup. The next bullet, I have the term composite bid. The composite bid essentially is the last man in number. CMS has a formula here where they determine how many they've already determined how many contractors are needed based upon the formula we talked about. And then they will be arraying all those bids from lowest to highest. And when they reach that number, they will stop. And at the point they stop, that is technically called the composite bid. It is not the same. It is higher than the SPA or the single payment amount, which is the bid price. Another area which may or may not impact this group, CMS is making a proposal to create a remote item delivery competitive bidding program. We have the items listed here. Obviously, they don't identify compression garments, so that's good. But these are items that are typically delivered long distance or via mail order. So in the interest of time, I won't review those. But this is a new proposal. And lastly, this is a significant change that CMS is proposing. I mentioned before that suppliers are no longer going to be reporting potential capacity in their bids. CMS is also proposing to reduce the financial documentation requirements. Previously, CMS required tax returns or tax return extracts, income statements, things like P&L statements and statement of cash flows. And they would do an analysis of the company's financial wherewithal to make sure that they would be able to expand to serve the competitive bidding area. CMS is proposing to do away with all of that financial documentation and only require bidders to submit a credit report, like a D&B, Dun & Bradstreet report. The issue with that, at least from my perspective, just is that a credit report paints a very limited picture and doesn't provide any information about a company's ability to really ramp up and provide an expanded population for a particular product category. So there's not a lot of good changes being proposed in here. In fact, I don't think there are any. It's important to stay tuned to this. Remember that this is a proposed rule. We'll stay tuned to see what the final rule looks like in the fall. And I think that's the end of my section. I'm going to turn it over to Heather. Thanks.
Thank you, Kara. It's great to be here today with everyone. So since shortly after the LTA went into effect, we've had a form available on our website where anyone can report instances of denials or simply insufficient coverage. So we could keep tabs on where improvements still needed to be made and where there continues to be gaps in coverage. We've received very few reports overall regarding Medicare fee-for-service coverage, and almost all of them were during 2024. And typically they were related either to coding issues or not providing the necessary documentation as suppliers and billers adjusted to the new requirements. By far, the largest majority of denial reports are related to Medicare Advantage plans. During 2024, it was common for these plans to still issue wrongful denials, citing the items as non-covered benefits, and sometimes even quoting the old Medicare policy of a wound needing to be present. The good news is this year we've stopped getting reports like that, but unfortunately many Medicare Advantage policyholders are still unable to utilize the new coverage that they're entitled to because of a lack of in-network suppliers. And this seems to particularly be an issue with United Healthcare plans, we presume due to their poor reimbursement rates. So luckily, we have recently been able to establish a line of communication with UHC thanks to a relationship I had established during my years of working on the LTA, because that individual is now an executive at United Healthcare. So therefore, if any of you are experiencing any kind of coverage issues with a UHC plan, and particularly if it's an Advantage plan, please do scan this QR code and use our form to report that information to us. Additionally, we would also especially like to hear from you if you're experiencing a coverage issue with a Medicaid plan, because Carmen and I will be attending the National Association of Medicaid Directors annual conference this November. So based on our research, some states have vastly improved their coverage since passage of the LTA, and a few state Medicaid plans have even fully adopted the Medicare coverage. But most of them still provide very inadequate coverage for lymphedema compression supplies. So there's a lot of work still to be done on that front. And lastly, with regard to private payers, there has been a good amount of movement towards adopting more coverage thanks to passage of the LTA, but it is still a mixed bag. And much like the Advantage plans, in some cases, the reimbursement rates are now a more significant issue than the lack of coverage is. So next slide, please. I'm really excited to share with you information about our new lymphedema supplier directory. This is not something our group had planned to build, but after finding that the Medicare supplier search tool was very inadequate, and after receiving a lot of questions from patients and therapists who were needing help finding a supplier that took insurance, we decided that there was a great need for this within the lymphedema community. Our new directory is 100% free for both suppliers and patients. Suppliers can add their own store or stores by scanning this QR code, then clicking on the register button in the upper right corner of the page and following the prompts to create an account. And patients can use the directory to locate brick and mortar stores near them by searching by their state or by their zip code. And they can also have the option of seeing nationwide online suppliers. So in this directory, it's not just a list of businesses. Each store has a page, and on that page contains their contact information, including a link to their website if they have one, the types of products that they sell and for which parts of the body, whether the measurements must be taken by their staff or if they can be submitted by a therapist or certified fitter, the store's level of experience with lymphedema compression items, because there are new vendors entering the space now that we have Medicare coverage, and also what types of insurance they accept, if any at all. So even if a store does not accept insurance, we still want them to join the directory. This is a resource, like I said, for just connecting patients to the best supplier for meeting their needs. We already have about 250 suppliers in the directory, but we need to have many, many more to make this a truly comprehensive resource. So if you have a store and have not yet joined the directory, we hope that you will. And as a segue into my last slide, I want to point out that this new supplier directory, as well as all of our educational materials, are located on our Lymphedema Education and Awareness Project website, which is at lymphedemaproject.org. For those of you who may not be aware, we launched this new group to work in partnership with the Lymphedema Advocacy Group. So the Lymphedema Advocacy Group is a 501c4 nonprofit and will continue to lead all advocacy efforts related to policy changes and improvements, while the Lymphedema Education and Awareness Project is a 501c3 nonprofit and will focus exclusively on all education and awareness related initiatives. So all of our free educational materials are on our new website at lymphedemaproject.org, and these items include our very popular information cards, which can be ordered 100% free of charge. They're printed on cardstock and meant to go into those information holders that are frequently used in business settings. On the front side, there is general information about lymphedema, and on the back side, it has information about the new insurance coverage. We also have separate handouts for patients, providers, and suppliers, and the information on each of those is tailored for each group. We also have a specific handout for Medicare Advantage, which is very important for helping those beneficiaries to understand their rights and what to do if they're not receiving the coverage they're entitled to under the new law. And while we're only able to provide the free printed copies of the information cards, all of these other materials are designed to be printed on standard paper and available for free download through our website. So we hope that you will take advantage of those items. And this concludes my portion of the presentation, and we look forward to answering your questions.
Thank you so much, Heather. I really appreciate you joining us today, as well as all of the other panelists. So with that, as I mentioned at the beginning, my name is Carmen Anderson. I'm here to support the U.S. Medical Compression Alliance. Currently, the member manufacturers are Jobst, Juzo, L&R, Medi, Sigbaris, and Tuan. And these companies have come together to try to share information as it's coming out. And that's what we've done with this webinar as well. We solicited questions in advance, and so I'm going to go through some of those. And then as time allows, we'll get into the Q&A chat box as well. So somebody asked, when a patient requires separate garments for the same leg, how are they counted? And what I did here was I pulled out the final rule language specifically from CMS. So they recognize that some patients, in order to maintain mobility, may require separate garments either at or below the joint of an affected extremity or part of the body. And Medicare recognizes that that may require multiple different garments. So it is allowed to break up those products in order to allow mobility for patients. Of course, you have to document that that area of the body is affected by lymphedema and make sure that medical necessity documentation supports that. There was a couple of specific examples submitted as well. So for example, does one thigh high and one biker short count as 2 of the 3 that are allowed? So they're referencing that daytime compression garments, standard or custom, they are eligible for 3 every 6 months per affected body area. And we wanted to say that no, it's not 2 out of the total 3 allowed. That one thigh high counts for 1 of the 3 allowed for the leg, and then the one biker short counts for the 1 of the 3 allowed for the genital abdominal area. Again, the key to this is medical necessity documentation that supports that each area that's covered by a lymphedema compression garment is affected by lymphedema. And so those different body parts are eligible for different quantities. Similar question, do shorts for genital or abdominal edema count towards the lower extremity allowable? And the answer to that is no. They're different areas, but the documentation must support that lymphedema is present in both separate body areas. One question asked if there would be updates to include the knee, and I think that's specifically referencing the adjustable wrap codes. USMCA has submitted HCPCS applications requesting additional codes, and specifically one for an adjustable I can talk, adjustable wrap specific to the knee. That request is currently pending with CMS. They wanted to see additional data, so we are in the process of gathering that data and hope to go back to CMS with more information to support the creation of additional HCPCS codes, including a wrap specific to the knee. Somebody asked, how do we bill properly for the separate wrap pieces? If the pieces are separate, like the foot, does that count as one body part? And we would say that you are supposed to bill for each appropriate HCPCS code, and that a separate HCPCS code does support a separate body part. There was a question about HCPCS A6519. This is a newer HCPCS code that just went into effect in April of this year. It's the nighttime, not otherwise specified code. They were asking if they should be billing a modifier for laterality. So does it need a right or a left modifier? And the answer to that is no. There was some back and forth between our expert panelists, and I believe there's going to be some updating within the DME MAC tools and websites, but those not otherwise specified codes typically do not require a right or left modifier. Additionally, someone asked, how can liners be covered as an accessory when these are changed more often than Velcro garments? My answer to that was that liners do not provide gradient compression. That's why they are categorized as accessories. An individual asked if there's coverage for patients who need bandage wrapping first and then maintenance garment later. The answer to that, and this comes from the final rule language and some of the DME MAC publications as well, is that compression bandaging supplies furnished during phase 1 and phase 2 are both covered when medically necessary for the treatment of lymphedema. So just make sure that they're enrolled as DMEPO suppliers, and there has to be justification for the quantities or replacement needs within the beneficiary's medical record. Another question is there coverage for items like chip bags, kidney shapes, textured textiles, and are there quantity limits? So yes, there are coverage for those. There's a couple of different HCPCS codes depending on the product. So it's either going to be A6609, which is the gradient compression bandaging supply, not otherwise specified, or A6593, which is accessory for garment or wraps, not otherwise specified. And same concept for the quantities limits. There is not a specific quantity limit. It can be determined by the DME max, but medical record documentation must support that quantity. Someone asked if there was an ICD-10 code for phlebolymphedema or if it was eligible for the benefit category. There is not an ICD-10 code for phlebolymphedema, so it is not one of the 4 codes that has been identified by the DME max because it is not an current ICD-10 code. So the eligible codes are I89.0, Q82.0, I97.2, and I97.89. One person submitted and asking questions about are there guidelines for children's insurance coverage, including newborns? So coverage is going to vary by payer and also by patient-specific health plan and benefits. So we always recommend that you contact that specific plan, do a verification of benefits, look at the medical policy review. But Heather had shared some really good information from her experience, of course, that nearly all states have a congenital anomaly law that would allow for coverage, especially for that primary lymphedema patient population. So since they're born with it, there should be some eligibility within that congenital anomaly law. One individual asked, why are Medicare Advantage plans different from Medicare? This is a very complicated question because Medicare Advantage is required to cover at least what Medicare does, but patient access issues often arise due to fee schedules with lower reimbursement rates. And so that's typically where the challenge comes from. So they may be eligible for a product, but if the reimbursement rate is too low, it makes it difficult for the suppliers to supply it and difficult for the patients to access it. So Heather and myself, we are partnering together, as she mentioned, the issues with UHC. So we are going to be approaching payers to try to tackle some of these challenges. Another question was, does the ordering practitioner have to see the patient and document the diagnosis of lymphedema? Medicare does not require a face-to-face encounter for this benefit category, but I would really encourage everyone to look at the standard documentation requirements article A55426 or the specific documentation checklist published for lymphedema compression treatment items that Belinda and Corinne mentioned earlier. So there are some great resources out there from the DME Max. Several people asked, how is the USMCA assisting with pricing? So we are advocating to Medicare for improved reimbursement through the HCPCS application process. That's how you try to address national payment amounts, and also collaborating with LAG to approach payers, like I mentioned for UHC. And it is important to call out that there was a 3% increase in the Medicare payment amounts for lymphedema compression items from 2024 to 2025. So we did see a marginal increase there on the Medicare side. We acknowledge there's work to do with the other payers. One individual asked, can we bill patients if insurance denies certain items? And that will very much so vary by payer. So for Medicare, you have to reference the Medicare Claims Processing Manual. And for other payers, it will depend on your specific contract. And I know that Noel got into quite a few details regarding that during his portion of the presentation. So that wraps up some of our submitted questions. Panelists, if you want to come back on camera, we can potentially tackle some of the Q&A that have been submitted. We've got just a couple of minutes left, so we can dig in here. Looks like we've answered a number of questions. We have a couple still open. There's a question about who can sign a prescription. We have a physician and also separate lymphedema therapist. can lymphedema therapist sign that is not a doctor's assistant? So prescriptions have to be signed by the physicians. And again, you'd have to look in the standard documentation requirements, or if there's policy specific rules about who can sign on a prescription as far as, NPs, PAs, whatever that looks like. DME Max, keep me honest, Belinda and Corrine, if there's anything beyond that. But my understanding is the prescription itself, typically physician, and then maybe some additional clinicians allowed depending on the policy specific article.
That's correct. That's my understanding.
Yeah, and just to add to that, when we say physician, for the Medicare statute, it does allow for other clinicians to sign a prescription. It's not limited to MD, DOs, clinical nurse specialists, nurse practitioners, so on, will have prescriptive authority. I think it really boils down to that state law and as to what clinician has prescriptive authority, and I doubt therapists will.
Yeah, it would be rare. I'm not aware of any. One individual asked if lipedema is covered, and my understanding is that's kind of similar to the lymphedema, that there's not a formal ICD-10 code, but then the recognized ICD-10 codes that have been published by the DME Max are the only codes. So again, this is specific to the Lymphedema Treatment Act, so it's limited to those 4 ICD-10 codes that have been published. Some of these get into state or plan specific questions. And so I just want to acknowledge, I see a couple of questions about Medicare Advantage and Medicaid. They're offering different coverage than what's happening from a Medicare perspective. Again, Medicare Advantage should allow at least what Medicare does. If you're seeing any major issues or discrepancies there, please use the LAG denial reporting form so that we can help assist with any discrepancies on the Medicare Advantage side. But from a private payer and a Medicaid perspective, the adoption is going to differ from Medicare. Maybe slower. We hope to have as much adoption as possible, but it certainly takes more time because they don't necessarily have any mandates to implement that coverage. And that also crosses over into some of these that are talking about not getting paid enough, lower reimbursement rates. And that's where I would encourage you all to continue to submit those instances to the LAG denial reporting form so we can try to track some trends and partner together to tackle those. With that, we are coming up at the top of the hour. So I really did just want to thank all of the expert panelists for joining us today and all of the webinar attendees that took time out of their afternoon to join us. We will be publishing a recording of this as well, and we look forward to chatting with you all again soon. Thanks and take care, everyone.